everyone. It is my pleasure to welcome you to today's CE presentation for our specialty pharmacy audience on COVID-19, keeping up with a moving target. My name is Cindy Zellner. I'm a doctor of pharmacy and a clinical associate professor here at the University of Texas Southwestern Medical Center in Dallas, Texas. And I'm delighted to be joined by Dr. Paul Allwater, past president of the Infectious Diseases Society of America and professor of medicine at Johns Hopkins University School of Medicine in Baltimore. Listed here are our faculty disclosures. We will be referencing some unlabeled and unapproved use of some investigational medications just so that we're bringing you the latest information on COVID. This educational activity is supported by an educational grant from Gilead. However, all of the content and materials that will be presented today were developed by ourselves as faculty presenters as well as our planning committee. Our learning objectives today are to describe the current management strategies for mild to moderate COVID-19, as well as evaluate treatment regimens for patients with COVID requiring hospitalization. And we do want to appraise the efficacy, safety, and indications for use for remdesivir. So the role of specialty pharmacy in COVID-19 really has grown throughout the last year of this pandemic. Just some basic, reinforcing our CDC guidelines regarding hand washing, social distancing, quarantine, and wearing a mask really have helped us to be able to avoid more infections. We are at the front of our vaccine rollout with education by pharmacists, which have really helped a lot of our patients be able to take the vaccine, really kind of overcome barriers they might have had or hesitancy, and we've been able to help them find vaccine locations. Many of you, like myself, are certified immunizers, so you may be providing vaccines at your pharmacies. And be able to ensure compliance with dosing schedules if the patients are receiving a 2-dose vaccine. Many of our patients who have been hospitalized with COVID need support after they're discharged, and pharmacies are uniquely able to provide this. A lot of times we're able to deliver prescription as well as over-the-counter medicines to their home. Some of our patients may have lost jobs throughout this past year and may need support from us by finding certain other providers in the community if their original provider isn't able to continue to support them if they don't have insurance. We've done a lot with patient assistance programs to be able to help patients continue to access needed medications. And most of all, for pharmacists, our huge role is always on counseling, on appropriate dosing, the importance of compliance, and any potential side effects that patients might have. The clinical course of COVID really varies. The majority of patients, over 81%, do have mild to moderate symptoms. That a lot of these patients can be managed at home or in ambulatory settings. Unfortunately, though, there is about 19% of patients that will require hospitalization. Those patients may have severe disease with hypoxia or large involvement of their lung. Other patients might be in critical condition and require ICU support for respiratory failure, shock, or multi-organ dysfunction. In the beginning of the clinical progression of the disease, our real focus is the actual increasing virus burden within the human body. At that point, antivirals and convalescent plasma offer our best option for really attacking the virus itself. As time goes by, our own immune system becomes a real issue. That's where we see the immune system kind of reducing the ability of the lungs to breathe because of chronic inflammation. We see hypoxia, respiratory failure. This can even lead to acute respiratory distress syndrome. And at this point, some of our immunomodulators or adjuvant therapies may be most helpful. So who is going to be in that 19% that may have severe disease? We don't know for sure, but there are several risk factors that have been identified with strong evidence that link them to that. Those include cancer, patients who have chronic kidney disease, lung issues such as COPD, also patients who are overweight with a BMI of greater than 30 or 40. Our patients who are pregnant or have cardiovascular disease, sickle cell disease, smoking, which can also contribute to lung damage, solid organ transplant, and diabetes. Our ambulatory patients is who we'll focus on next.
Thank you, Cindy. What a great introduction. I've been, as many of us, working now over a year, thinking about COVID, working on COVID floors as an attending, but there still remains many questions. And home care is one that continues to sometimes be a source of concern. For example, people that are in who have developed COVID-19 do need to stay in for at least 10 days, assuming resolution of symptoms. And because there is the potential for developing infection after close contact, 14 days remains the standard CDC recommendation, although they've relaxed it a bit with less than 10 days if there are no symptoms, and 7 days if you are able to test and test negative there. Now, some states have different rules, but these are what the CDC currently is recommending. Now, for outpatients, we really don't have a lot of options other than supportive care, but there are now 3 different monoclonal antibody products that are available for patients with mild to moderate COVID-19 who are outpatients. They cannot be infused in the hospital. That's not how the FDA gave their emergency use authorization. But for example, the first one that was approved back last fall was bamlanivimab. And all these studies were first organized as virologic studies, looking to see if the monoclonal could suppress viral production. But those endpoints, at least in this study, were not met. But the secondary endpoints, which you would argue might be more clinically useful, included, did these patients actually get ill enough to land in the hospital or an emergency room visit? And you can see there was indeed a difference with people receiving the monoclonal less frequently requiring care. Now, interestingly, in how the FDA authorized its use was to target high-risk patients, which Cindy reviewed those groups. And in this study, at least, people who were older and who were also had a high BMI had a bit more improvement than the entire group. So the EUA really targets those high-risk people. And recently, that monotherapy monoclonal really won't be made anymore. So when those supplies are exhausted, you won't see bamlanivimab by itself. Instead, this combination product, a cocktail of 2 different monoclonals, which includes the second one, etesivimab, has had recent publication in January in JAMA. And this was the BLAZE-1 trial, which was in part what gave the FDA approval back in November. This one targeted people certainly that were people of color and also had risk factors. And again, you saw the same kind of difference, which was especially magnified in high-risk patients. Now, this product was given anywhere from over 20 to 60 minutes infusion. And this was more helpful because it's given faster, not tying up infusion staff at centers with the bamlanivimab, which is over an hour. The other monoclonal cocktail is the casirivimab and indivimab. This also has an EUA approval, and this was a product that President Trump got. And same kind of population, also with risk factors. And this particular trial has stopped in some groups, no longer needing placebo because of perceived efficacy here. And indeed, you get the same kind of bar graphs with improvement and less need for care in patients that got the monoclonal antibody there. And it's really the same population. So if you look at some of the recommendations, now the guidance from the NIH or IDSA tends to favor that when it's been peer reviewed. So at the moment, that really is the bamlanivimab and etesivimab cocktail. And it does recommend use for those at high risk, which is in fitting with the FDA. The other ones, they say there's insufficient data because some of this has not yet been fully published. But I think you'll see probably the combination casirivimab and indivimab all likewise join that recommendation. So who do you consider? For me, I have outpatients. I actually do still a bit of primary care along with infectious diseases. And it's anyone with those high risk for complications. It's going to be adolescents or adults. Now, the trials, on average, people got it within about 4 days of symptom onset. The EUA says up to 10 days, but honestly, I don't think you're going to get much bang for your buck if you're referring patients a week or more into illness, unless if they have a profound immunodeficiency and can't make antibodies. So, for example, someone like who is getting rituximab and so on. The infusion rate is 1 hour, although there's some modifications to that with the bamlanivimab and etesivimab product, and you have to have crash carts and so on available. But honestly, there have been very few side effects in these trials. So when do you consider? I really think of it as this is the only treatment we have that can try to help stymie progression. Patients who are elderly, obese, any of those comorbidities, I like to think and refer. Here in the state of Maryland, we have certain centers where this is administered, and you have to be referred. States are handling it differently. Some are giving it in emergency departments. However, none of these monoclonals are approved for hospitalized patients. There's still some trials ongoing. Some have been halted because of lack of effect, but this is one of the few treatments we have as an outpatient right now that's at least investigational, but the FDA is supporting its use. And I think of it as an antiviral type compound. Now, if we go to hospitalized patients, and I was on the COVID floors as an attending in January when we really had many, many patients, it gave certainly a spectrum of how we're trying to help these patients that are coming in, most of whom have COVID-19 pneumonia, but may also have varied presentations. As many of you know, the antiviral that's used in the hospital is an intravenous prodrug, remdesivir. It was originally purposed for Ebola virus, but also had in vitro activity against coronaviruses, was studied in MERS, for example, the Middle East Respiratory Syndrome. And so the drug, which is then metabolized to an active molecule, the GS441524 molecule, actually inhibits the RNA replication. So you're not generating the subgenomic RNAs that can then make proteins. So you're decreasing new viruses in infected host cells. Interestingly, the manufacturer is studying just the active molecule in of itself to see if perhaps it's more potent than the prodrug or working faster. And this is now the only FDA-approved drug for Ebola virus, and it's based on this pivotal phase 3 trial, placebo-controlled, randomized, that looked at time to recovery as its primary endpoint. Now, this was done earlier in the pandemic, and there was a difference of 5 days, which was statistically significant, and also at day 29, a trend towards decreased mortality that just missed statistical significance. When you look at what's driving that improvement in symptoms, you see the curves here for the entire population, which looks favorable for remdesivir. However, if you dig into the subgroup analysis, the group that benefited most were those that needed oxygen. And this makes some sense because most people who were admitted to hospital needed oxygen, and that's earlier in illness. So you saw that it was also one of the largest subgroups in this particular study, whereas those that were further along in illness who needed mechanical ventilation or even ECMO, the curves were nearly superimposed. This is going to be later in illness. You wouldn't expect an antiviral to have as much effect in the ICU, where people are having more of that hyperinflammatory response that Cindy had mentioned. The safety profile of remdesivir is actually very reasonable. There's no great signals. You don't want to administer it if you have someone with more than 5 times upper limit of normal of liver function tests, but generally placebo had more side effects than the drug, which speaks generally to the fact that this drug perhaps helped moderate the illness. So the guidelines from the NIH and IDSA both endorse its use for people that need oxygen, but not, at least for the NIH, if you're more ill in the ICU. For example, IDSA has remained with consideration in that group because some other trials may have shown some benefit there, but I can tell you in our hospital, we really limit it to earlier use for people on oxygen. Now, another set of antiviral medications could include something that wouldn't normally come from the pharmacy. It's coming from the blood bank, and it's convalescent plasma. And so this is a long history of use in infectious diseases, and most of us think of it as neutralizing the virus by antibodies, but may have some immunomodulatory activities as well. And the 2 studies I think have most informed how we might consider using it. We're still waiting for sort of the study that says, aha, this is an approach that we have to use. But this is a data from the expanded access phase that the FDA gave for convalescent plasma. Those of you remember, the FDA allowed its use without having to do copious paperwork in a trial. And these investigators, Mike Joyner at the Mayo Clinic, did a sub-study and tried to get at whether convalescent plasma helps patients. And there are 2 key points from this slide. I would say first is that high titer units of plasma really generated the most benefit, as you can see in the blue. And the second is high titer work better if they got it earlier. That is, they're not on mechanical ventilation. Again, as an antiviral, giving plasma when you're already in the ICU, you wouldn't expect much antiviral effect. So giving it earlier seemed to suggest that there was improved mortality, reduction of about 35%. Another study that has informed me is this trial from Argentina, a smaller trial, but a well-done one that looked at people over 65. Now, they were outpatients and only had mild COVID-19. So this is a lot like the US monoclonal antibody studies. And they got high titer plasma within 3 days of symptom onset. It was definitely high titer. And you can see here a rather marked risk reduction to significant COVID-19 pneumonia that might require hospitalization. Again, pointing to the fact that early administration may be helpful. Now, if we move to immunomodulators, this is a very active area. You're going to hear a lot more trials going on in the near future of different compounds, because there are many that are used in the rheumatology world that have been repurposed and under study for COVID-19. But the drug that surprised many of us that has really become the standard of care is dexamethasone. And this is a steroid which really had flunked ARDS trials in the past, although some of the data was mixed. But this is this is a very monolithic process, as COVID-19. So unlike prior ARDS trials, which may have been from all sorts of different causes. And this pragmatic trial from the United Kingdom called the Recovery Trial found that if patients were placed on dexamethasone in the ICU, there was a marked reduction in mortality from over 40% to just under 30%. A smaller one if you're on oxygen, but if you didn't need oxygen, a trend towards worsening. So this particular approach, I think, has been adopted widely throughout the United States for pretty much anyone on oxygen. It is started on dexamethasone at a 6 milligram per kilogram dosing, either oral or IV. And this was the first drug to clearly show mortality benefit in certain groups. And the biggest was, as I mentioned, in the ICU, but even people on oxygen appeared to have benefit. Now, some have said, well, this recovery trial, if you look at the UK, the mortality rates were much higher than we tended to see in the United States. So is this really what we see here? A little hard to answer that question, but it certainly has been adopted by most hospitals and critical care specialists for their patients, usually in combination with remdesivir if used on the floor. Now, a drug that I would like to just spend a couple of minutes has an evolving story, tocilizumab. Tocilizumab, those of you who may remember, was advocated by the Chinese guidelines way back in winter of 2020, mainly based on the fact that COVID-19 has this hyperinflammatory phase, which seems to resemble cytokine release syndrome, which you can see as part of CAR T cell therapy in the oncology patients. So this drug is an anti-IL-6 receptor blocker and is also used for rheumatologic diseases. But when this has been used in carefully designed studies as monotherapy earlier, they all flunked. And so this drug was used to some degree. We used it in our hospital in the early months. And then really by summer, we were no longer using it after the recovery trial and the positive effects of dexamethasone. But then this last trial, the impacted trial, came out. This was an interesting study that enrolled many people of color. It was multinational. And this was a positive trial where tocilizumab seemed to yield benefit by decreasing needs for mechanical ventilation and avoiding death. Now, how is this different from the earlier trials? Over 80% of the patients were also on dexamethasone. And indeed, 2 more trials where people were on high amounts of dexamethasone are positive trials for tocilizumab. The REMAP-CAP trial is one that you may have heard of. That's been an ongoing pragmatic study for pneumonia. And when the pandemic occurred, they decided, well, we better study this form of pneumonia. And they elected to study tocilizumab and its and the relative sarilumab in a much smaller number versus control. Now, 88% of people were also on dexamethasone because they got standard of care as this trial enrolled people after the recovery trial. And the primary endpoint was either avoiding death or days of organ-free support. And what was rather remarkable is a 10-day delta in improvement, and then also decreased mortality, 35% to 28%. So this was quite impressive. It was a preprint, and now it's been published in the New England Journal. And then the UK study, the recovery study, which we just discussed about dexamethasone, had released its initial results looking at tocilizumab. And this trial, too, over 80% were on steroids. Now, this group needed to be on high flow oxygen or just in the ICU and got a single dose, the standard 8 milligram per kilogram of tocilizumab. And it definitely reduced time to discharge, as you can see here, decreased need for ventilation, and also about a 4% difference in mortality. So based on those, if you look at the subgroup in the recovery, what really jumps out to me is that if you were on steroids, you can see the patients perform much better with the use of tocilizumab. So this, I think, really speaks to the fact that there could be some additive benefit for the more ill patients, those people that are really progressing on high flow oxygen or landing in the ICU. And if you look at a meta-analysis, there's definitely a trend towards improvement, and most of that is going to be driven by the studies we just talked about that most patients, over 80%, were also on steroids. That's Impacta, Recovery, and also Remap-Cat. So just recently, the NIH updated its guidelines to suggest that you should use tocilizumab in your patients in the ICU or who have rapidly escalating oxygen needs, such as high flow nasal cannula, non-invasive ventilation, and it should be used in combination with dexamethasone. The IDSA also suggested tocilizumab in addition to standard of care a bit earlier. So I think this is one of those moving targets as our talks are organized now that really speaks to how this cumulative data does drive different decision makings, and tocilizumab is now something that certainly if you're taking care of patients on the hospital floor in intermediate care or ICU units, you may wish to consider. I'll close this segment with the Act 2 trial. There's 4 Act trials. You heard about Act 1, which was remdesivir. This is Act 2, using a JAK1, JAK2 inhibitor called baricitinib that is used for rheumatologic illness, decreases inflammasome activity, and the thought was this may work well in COVID-19. And so this again was compared, it was remdesivir in both arms, placebo versus baricitinib. The difference here was only 1 day, but it was favorable to baricitinib. But the subgroup analysis says that the people that drove most of this improvement were those on high flow oxygen, so-called ordinal scale 6. Many of these trials have an ordinal scale for their clinical status of COVID-19. And so this was very much the same group that you might consider tocilizumab. At the moment, I can't say there's widespread use or enthusiasm for it. Both the IDSA and NIH say it may have a role for people that can't be on steroids, but there's not much more to say at this time. I don't see it used very widely. In our hospital, I've seen a use a handful of times. But importantly, the Act 4 trial, which is in progress, is going to compare remdesivir and dexamethasone versus remdesivir and baricitinib. So it'll actually be a head-to-head comparison for superiority. So probably later this year, we'll have some insights if we should be making a change with either of these agents. So now I think we're to prevention.
So prevention of COVID is going to be an important point, especially for our pharmacy colleagues to understand. So what about some of the antibodies that Dr. Allwater just went over? We did think about these as antivirals. So what about in a patient population where there's been an exposure for COVID? So bamlanivimab and the combination MAB products, casirivimab and indapamab, have been studied in a setting for prevention. Bamlanivimab was studied in skilled nursing and assisted living facilities where there was an exposure, and we saw the greatest reduction, an 80% reduction in COVID-19 infection among our nursing home residents, which are a very vulnerable patient population. There were also, importantly, no COVID-19 attributable deaths in the bamlanivimab arm. In the combination MAB products, we saw that being studied in household members. Many people live in very close quarters with one another, and it's difficult if you have a household member who has COVID to completely isolate that person and quarantine them from the other members of the household. So this was an option for prevention, and we saw 100% prevention of symptomatic infection in this, 50% overall lower total infection, and overall a decrease in viral shedding that we saw in this group. So this may be an option, again, in an ambulatory setting for prevention. Vaccines, though, are where our pharmacists are standing on the front lines. Many of you are preparing for your pharmacies to either continue to be a part of the rollout or be added to the rollout. We have 3 products that have now received emergency use authorizations from the FDA. I'll go over each of these in a brief detail, but I really want to focus on the center of this slide. All 3 products in all clinical studies, and these have been studied in almost 60,000 people. For all vaccines, we saw 0 COVID hospitalizations and 0 deaths. That's the most important point that you can convey to the people that you're looking to vaccinate in your pharmacy, is that this vaccine is a way out of this pandemic. It's preventing hospitalizations and death from this disease. The newest product, which just got emergency use authorization on February 26th, is the Johnson & Johnson, or the Janssen product, and this is a single dose. Additionally, this medication can be stored in a normal refrigerator, and it actually, for vaccine clinics, can actually be kept at room temperature for up to 12 hours before it's punctured. So that may be a wonderful option for a lot of our pharmacies that are looking to do some vaccine support for the rollout. An update that I would like to go over that happened for the Pfizer in biotech product is the guidance on storage. So the FDA updated their information on February 25th to state that, originally the Pfizer product was only shipped in the ultra cold freezers, and now it can be shipped and stored in a normal freezer for up to 2 weeks, which expands, of course, the ability to be able to do that. Again, all 3 products make wonderful options, and I really would encourage all of our pharmacy staff to really try to encourage patients, their family members, to become vaccinated. So American Pharmacists Association studies show that there has been a high level of vaccine uptake by pharmacists. 9 out of 10 surveyed have already received the vaccine or plan to take it as soon as it's available to us. 95% expressed comfort in addressing patient vaccine concerns, and 79% felt staffing levels were sufficient to handle the vaccine rollout. The APHA Executive Vice President and CEO stated that pharmacists are ready, willing, and able to protect Americans against coronavirus. Over 400,000 pharmacy staff have been trained as immunizers for precisely this moment, and we're ready to do the job. So in summary, monoclonal antibody treatments are available for outpatients at high risk of progressing to severe disease or hospitalization. Antiviral treatments with remdesivir is the only FDA-approved medication that we have for hospitalized patients. Patients who are on oxygen but not receiving mechanical ventilation, or ECMO, benefited the most in the Act 1 clinical trial. The duration of illness was reduced by up to 5 days. Antiviral and antibody-based therapies appear to work best when given as soon as possible in the course of the disease, whereas dexamethasone can reduce mortality rates in patients with severe and critical COVID who are in the ICU and do require mechanical ventilation for support. And with that, we'll entertain some questions from our audience. The first question that we have from the audience today has to do with remdesivir. What is the optimal time, in your opinion, to initiate remdesivir?
Yeah, Cindy. So this drug, as many of you know, is fully FDA approved, which means technically you could use it anytime you want. It's no longer an investigational agent. But the studies do suggest that it's people that are a little more ill who require oxygen. So if someone's admitted, let's say they have an upper GI bleed and found incidentally to have COVID-19, I don't think we're using it in that group of patients. But to be honest, in the Act 1 study, they had very few patients who were not on oxygen in the hospital, as you might imagine. So we really haven't studied it in that earliest group. I would say, to me, if someone's ill enough to be hospitalized, that's a good patient population to start remdesivir, especially if they're in the first 7 to 10 days of their illness. I think if people are being admitted later, 10, 14 days or more, you're really talking about other complications, superinfection, Kappa, the aspergillus complications of pneumonia of COVID. You may be still dealing with hyperinflammatory responses. So people that you can clearly date longer, I probably would not at all consider it in that group. And the free drug is gone, right? So your pharmacies are the ones ordering this, and it's not an insubstantial cost. But if you look at it as saving days of hospital stay, I think it certainly likely still passes the muster and benefits for use.
In thinking about some of our other options, with the emerging COVID variants that we're seeing in the news and in media, are the current antibody combinations expected to be effective?
Yeah, so this is going to be an interesting and evolving situation. Of course, worries many people, not only our patients because it's in the news, but also public health officials and vaccine experts. But at the moment, the key message I'd say is I'm optimistic that all three of the vaccines we're using in the United States appear to be helpful against any of the known variants. So we know this from some test tube data where people who have had the vaccine, we tested plasma against the coronavirus, and it seems to neutralize it. These variants, the one first described in the United Kingdom, one first described in South Africa. These variants, it didn't, you needed a higher titer. It didn't work at quite the same dilutions, but I think everyone feels they're still protective. We know the Janssen, the J&J vaccine, the one jab adenovirus-based vaccine, was used primarily in a study in South Africa where the circulating variant B1351 is really the one that has the somewhat notorious mutation in it now. And at least, even though that that vaccine wasn't fully protective, as you said, it protected people from going to the hospital, so severe COVID and death. So I think they are still protective against the variants. We're obviously watching that. You mentioned convalescent plasma. That's a little different story. I think if you have high titer units, it looks like you'll do fine against the UK described variant. There's been some suggestion of escape from the 1351 variant, the one described in South Africa. So it's not exactly clear, and there's some concern that reinfection or secondary infection may occur in people that had COVID months ago and they're exposed to the new variant. So this story will likely evolve. I caution everyone to just be wary. A lot of the newspapers are reporting on new variants in the United States. No doubt they're here. We don't quite know how widespread they are. We're just beginning to get a handle on that. But it seems like new variants are being described all the time, and maybe they are, but it's hard to get over concerned about them at the moment. I call them scariants instead of variants because the newspapers like writing about them. But the good news is, we're not yet seeing a big uptick. Now, in Europe, there have been increases in cases, and they've usually been ahead of us by several weeks. So it's still important that people, socially mitigate when they're out in the public and so on. So this is quite an evolving story. Sorry for the long answer, but there's a lot to unpack in those two questions.
Oh, I think that's very helpful. You mentioned this in the talk, but we have a question to clarify why bamlanivimab plus the combination with estivimab would not be used in a hospital setting.
Yeah, so this has come up because we've had some severely immunodeficient patients where we thought these monoclonals might be helpful. Our lawyers say because it's an investigational drug and it's under emergency use authorization, we can't give it outside of its EUA indication, which says clearly outpatients. Now, There are emergency room administrations. Again, you're not an inpatient there. So I think even though it could have a role in certain populations, until the drug is approved, we really can't use it outside of its investigational EUA that the FDA has granted, or at least not run afoul of the FDA and your hospital attorneys.
And you commented about the use of baricitinib in combination with remdesivir. Is that something that you think will probably move forward as a real positive option, or what are the early signs for that?
I think it's unclear. I think people are so used to using dexamethasone. We clearly had more of a mortality benefit. Granted, it was in a different kind of trial, a pragmatic trial, as opposed to a gold standard RCT that the baricitinib was in, but that was just a 1 day difference. So I think a lot of people were not as excited about it. And again, that was a group that got remdesivir. They didn't get dexamethasone. So it'll really be the head-to-head comparison to see which performs better. The high flow oxygen, that ordinal 6 group, was very interesting. And so a couple of our clinicians have thought about it much the same way that we're now thinking more about tocilizumab. But I think the data is now stronger for tocilizumab for those patients. And we're using it on top of dexamethasone. So I think we'll hear more about baricitinib, but I don't see widespread use at this time.
And kind of staying with questions on remdesivir, have you needed to extend use beyond 5 days?
So in our hospital, we have an ability to request an additional 5 days, but it has to be approved by our P&T chair. So it's on a case-by-case basis. The only time we've really done that is for people that are profoundly immunosuppressed. Maybe they're in their 20 or 30th day of illness. We feel like we almost have to retreat them. We do a swab of their nostrils, for example, and find lots of virus there. The CT values are very low, perhaps 14, 16, really indicating that there's still lots of active viral replication in this immunosuppressed patient. And those are where we're using remdesivir with convalescent plasma in an effort to try to effect some immune clearance and treatment in those kind of patients, but pretty specialized. So we're not routinely using more than 5 days.
We have a question about some other therapies. They're investigational. Colchicine. Have you had any data that you can share with us about that?
Sure, Cindy. On that one slide, the pictogram that you had of the phases of illness, adjuvants were right at the bottom. And there have been a lot of them that have been studied, so far, thought about: vitamin C, vitamin D, ivermectin, who knows? And colchicine is one of the adjuvants as a sort of anti-inflammatory, perhaps. So the study that I know was a preprint out of Montreal, was an RCT, reasonably sized, where people had to take it for 30 days, but they had outpatient mild to moderate illness. And there was only about a 1% difference. I think it was like 4.6 to 5.7 or something like that in terms of progression to illness. So, again, when you're just dealing with a 1% difference in two different arms, it's not getting people too excited that there's a great effect. There might be some. How that drug was used there was just like gout, twice a day for 3 days, and then you drop down to once a day, almost as a lower strategy. So I've seen some clinicians use it. We don't use it in the hospital, but there's not a whole lot of data to back up its use on a frequent basis.
As far as other therapies, are you aware of any data on, I may not pronounce this correctly, molnupiravir?
Aha, someone's been watching that carefully. Yeah, this is a product, an oral antiviral that was originally brought by Ridgeback Pharmaceuticals, now is a Merck drug, actually. So I have not been watching CROI today, unfortunately. I was tied up in meetings. But there is some preliminary data that I'd seen that suggests some effect that were in some slides that were shared ahead of CROI. But I haven't seen the CROI presentation, which I assume had the more robust information. So your pharmacy colleague there is way ahead of me on keeping an eye on that.
And then next couple of questions have to do with the vaccine. There's a question about how much of a kind of a grace period is there between your timing of your second doses for Pfizer and Moderna. And so I'll answer that question first. With Pfizer, we have pretty clear instructions that we can give it as early as 19 days and as late as 6 weeks or 42 days. The recommendation, of course, is 3 weeks or 21 days. With Moderna, we do have a little bit more leeway there also. But the goal would be that patients would get the second dose as soon as possible, as if they can. Another question about the vaccine was, what if you needed to use a different manufacturer for the second dose? Currently, that is not recommended. It's recommended if you start with the Pfizer product that you would continue with the Pfizer product for the second dose. The same for Moderna. If you started with the Moderna product, you would get Moderna for the second dose. And I'll see if you have any thoughts to add to that.
Yeah, so right. So there, I agree. It's nice to try to give it on schedule. There's of course a huge debate about delaying a second dose so more people can get a first dose, and that has not really been adopted here in the United States compared to the UK, for example. The UK also had more of a mix and match policy, and we have some allowances that if someone's really short, you could swap in another vaccine, but it's not being recommended.
And then if a patient, did have COVID and was hospitalized or, and got it, or, the alternative, maybe they were on an ambulatory side and they received a monoclonal antibody, what would be the time frame before getting a COVID vaccine?
Yeah, so typically it's 90 days is the typical advice for waiting. I think you can sometimes wait a bit more. We know data from the UK, large public health data there, that patients that recuperated from COVID-19 seem to be well protected at least 8 months. That's, again, this is going to be rolling data. So they'll probably be presenting 10 and 12-month data. So we'll have some idea as time goes on, but 90 days is the current recommendation as a minimum. But I tell people you probably don't have to hurry, unless, again, you might have lots of comorbidities. You may be, someone that's in their 80s or 90s, perhaps with immune deficiency. Then I think getting an immunization as sooner rather than later makes some sense.
Kind of staying with the theme of vaccine questions, what is the latest information about whether or not we'll need booster vaccines for next year to combat some of the variants?
Yeah, I think that's to be determined. At the moment, it doesn't look like we need it, but some of the companies are already incorporating some of the variant genetic sequence S protein into their vaccine as a potential booster. And those studies are going to be underway. One of the beauties with the mRNA technology is it's really a matter of weeks to make that kind of change there. So, we'll have to see. These mRNA vaccines are really remarkable in that they really have engendered good immunity because you're presenting really just one protein. You're not distracted by other proteins like some of the other viral vector vaccines, and you get pretty good T cell responses too. So, we'll have to see how this all pans out. And even the J&J vaccine, there is a 2-dose regimen being studied. Again, whether a booster is needed for the people that receive J&J, that's something we'll know more about probably late this year.
And this comes up with some other vaccines. Is there any information about giving a COVID vaccine to a patient with a history of Guillain-Barré syndrome?
Yeah, I think people always worry about this mainly due to influenza and some of the advice there. Uh, at the moment, there is not really any word that I've heard that these vaccines have stimulated Guillain-Barré above any background incidence that normally occurs. So, one of the things that I think that's very true about these vaccines, to think of the people that shouldn't get it are very few. I mean, it's people that have anaphylactic reactions to vaccine history. That's about it. These are non-replicating vaccines. They don't incorporate into your DNA. You don't have to worry if they're immunodeficient or on medications. Everybody can get it. I mean, even pregnancy, although we don't have lots of data, OB gynecologists, ACOG, are suggesting that you talk to your doctor and recommending, because pregnancy is one of the high risk groups for COVID-19.
So kind of staying with our vaccine questions. First of all, this is a very unique question. It says that if a patient gets 2 doses of the Pfizer vaccine, but the IgG spike test shows very low antibodies 4 weeks after, what do you recommend? Could you use a dose of another mRNA vaccine since it might work differently? I can say for our institution, we don't even have a lot of that testing that's being done for patients.
Cindy, I think that's right. We really don't understand the correlates of immunity with these vaccines. I think there's a focus on the spike antibody, rightly so, because they're spike vaccines. But on the other hand, as I've already mentioned, you get T cell responses and so on. So at the moment, I don't think there's any general recommendations. People do worry. They want to get their levels checked. I think, again, it's sort of having some sense that you're well protected because you might have antibodies, but there's no recommendations to do that at this time. Also, we're not quite sure of the meaning. So no boosters at this time.
And this kind of goes back to the monoclonal antibody question. It is going to take time for us to roll out, the vaccines across the United States. The current projected target is May. But is there any effort to kind of greater expansion of the monoclonal antibody for prevention under their EUA?
Well, I think that's a difficult question. It depends a little bit on FDA decision making, whether they actually fully approve the drug. I think it's still being distributed to states, much like vaccines. So there's not abundant monoclonal antibodies. I think it's interesting, Cindy, you discuss the prevention data, for example, in nursing homes and close contacts. Clearly, that's where this drug probably has its real strength. Hopefully, as more people get immunized, there's less of a need to go and administer an IV or sub-Q drug to people in nursing homes and facilities. But it is a way for protection. You might imagine some people, for example, that may be without homes or living in congregate living, have sort of disorganized lives. If they go to the emergency room, potentially they could get, an injection of these monoclonal antibodies for protection. But, there's still not been an EUA for those. So, I think the focus, to be honest, is so much on vaccines, and I think it's a good focus at the moment, that there's a little less on the monoclonals at the moment. But I think they definitely have a role, and I really like their use. And I would encourage any of the pharmacists here. I mean, I know a lot of my clinicians, really look to the pharmacists for this kind of advice. So I know I do. So it's great to just be knowledgeable of the hows, whys, and wherefores for this, because it's not always obvious to clinicians that may only think about things occasionally.
Yeah, the administration of the monoclonal antibodies has been difficult for most people to, kind of operationalize as well. And versus the vaccine rollout, where we've got a lot more of our focus right now, people are finding ways to overcome any operation challenges for that. And like you said, I mean, our efforts across the United States have been to try to vaccinate those people who are at greatest risk for severe illness. Another vaccine question, have you heard any information about the COVID vaccine and Bell's palsy?
Yeah, so there have been a handful of cases reported. Again, whenever you have something that happens normally, like Bell's palsy, and you're immunizing millions of people, there could be an apparent temporal relationship. And again, I would encourage anyone that does see this to report it to VAERS, the Vaccine Adverse Events Reporting System. That's the only way we're going to know if it's happening more frequently than background. But again, whether it's true or not, it seems to be very infrequent. And again, especially for people with risk factors, I always say the vaccine themselves seem to be very safe. And when you're comparing that with the dangers of the infection itself, I say that, the vaccine really should be as natural as putting your seatbelt on in a car, and it gives you that extra safety and assurance.
Kind of switching back to our hospitalized patient, we had a question earlier about extending remdesivir. What about discontinuing remdesivir before the 5 days?
Absolutely. Yeah, we do that all the time. If someone's improved, we stop it at day 3, day 4. Sometimes patients have very marginal oxygen requirements. They improve within a day or two. We stop the drug, send them home. We don't complete the course.
And then going back again to our hospitalized patients with steroids, have you seen any issues with using steroids in patients who have asthma? Mostly the dexamethasone would be being used in the ICU setting.
Right. I haven't, not that I've heard of. If sometimes people are on relatively high doses of steroids already, and those are the people where I think baricitinib's been used, just because they're already ill, they're already on steroids. So that's where I've seen that. But in terms of the remdesivir effect, no.
And then our last question, what study are you most excited about to see for hospitalized patients?
Oh, hospitalized patients. Well, let me answer a different question. What am I most
Go ahead.
excited about generally would be oral antivirals, because if you think about it, we'd love to have a drug like oseltamivir that we could start day 1 of symptoms. We know it's going to have much more impact if you actually have a potent oral antiviral drug. In terms of hospitalized patients, there are a number. You saw my conflicts of interest, so I can't really say very much, but there are going to be a number of additional immunomodulatory drugs out there in trials. So you'll see some very high quality studies that are looking at alternative agents that are usually added on top of standard of care, and see if that helps our patients, the most ill in the ICU, the ones that are really at risk of death or extremely prolonged hospitalization.
Well, this has been an exciting hour. Thank you so much, Dr. Atwater, for all of your valuable information that you've shared with us. Thank you for everyone for the insightful questions. We hope that we have armed you with the information you need to go forward and treat patients as well as prevent COVID through vaccination efforts. And we thank you for your time and attention today.